This would be Chapter 8, Communication Skills. So as humans, we have this fundamental need to relate to others. We have an ability to communicate. This gives our lives sustenance and meaning. We also share a need to be understood, and we form satisfying relationships with other people. This is usually accomplished through effective communication skills. However, when we have stress or when negative feelings occur in a relationship, our communication is often broke down. There's a much greater chance when we have that negativity, and we also face a greater chance for miscommunication. All of our actions, words, and expressions express or convey some meaning to others. Some people say we cannot communicate. Silence, for example, can communicate things such as acceptance, anger, or thoughtfulness. Social relationships are different from therapeutic relationships. Basic communication is different from professional communication. Goal-directed and scientifically based communication we call therapeutic communication. So just as your social relationships differ from your therapeutic communications, your basic communication is going to differ from that professional communication that you have that's directed towards meeting those patient goals and including that evidence-based practice. This is all part of the therapeutic process. Now, as we talk about this therapeutic relationship or this patient-centered care, this isn't a new concept for you as a nurse. And as you move towards mental health nursing, this is going to be more important because when you're taking care of someone on a med-surg unit, even though you're meeting psychosocial needs, you're addressing most of the time those physical components. But when you're dealing with a mental health patient, you're going to be dealing with much more conversation. You're going to have that communication. You're going to have to build that trust and rapport in these people because remember, a lot of them don't have a trusting relationship with anyone, not just the nurse, anyone. A lot of them are paranoid and they don't believe some of the things that we believe in modern medicine, or they may not believe in the concept because of things that voices or other things that are going on in their brain. So we need to form this patient-centered therapeutic relationship. It's essential to effective nursing care. Therapeutic communication is crucial to the therapeutic relationship. When we determine the levels of pain in the post-op patient, when we listen to parents express fears about their child's diagnosis, we understand without words the needs of the intubated patient in the intensive care. These skills help us provide quality nursing care. Therapeutic communication is a professional skill. You'll learn it, you'll practice it, and as you practice it, you'll get better. In psychiatric nursing, communication skills assume a different and new emphasis because psychiatric disorders cause not only physical symptoms such as fatigue, loss of appetite, and insomnia, but also emotional symptoms, sadness, anger, hopelessness, euphoria, as well as sensory distortions. These affect a person's ability to communicate with others. So it's not just your communication skills, it's their ability to communicate with you. Often in the psych rotation, students discover the importance of communication and increase their ability to utilize that therapeutic communication and begin to rely on techniques they once considered artificial. There's a fundamental difference between performing an assessment and using therapeutic communication. Assessment is an information gathering approach that's designed to meet the nurse's needs, whereas therapeutic communication meets client needs. With continued practice, you'll develop your own style and rhythm, and eventually the techniques will become part of the way you communicate with others. With time and practice, you'll begin to relate to the person behind the diagnosis and to experience, to some extent, the world through the eyes of another person. Inexperienced practitioners are often concerned that they may say the wrong thing, especially when learning to apply these therapeutic techniques. Will you say the wrong thing? The answer is yes, you probably will. This is how we learn to be more useful, find more useful and effective ways of helping our clients reach their goals. Your challenge is to work with your instructor or supervisor to find more useful responses. Will saying the wrong thing be harmful to the patient? Hardly. Especially if your intent is honest, your approach is respectful, and you have a genuine concern for the patient. Remember, we talked about this. So, one of the things that you should do whenever you walk on the floor, I don't care if it's a psych unit or not, is when you're walking past people, say hello. Say good morning, because people don't do this. And then they go to the patient and they want the patient to do certain things, and the patient feels some kind of way because you couldn't even speak to them coming in the morning. So now they've formed a judgment about you, and you're going to have to overcome that barrier in order to start building trust. So let's just start off on a good foot and treat people like they're human. Doesn't matter what their problem is. It doesn't matter where they come from, who they are. Just treat them as human. Communication is about 90% nonverbal. Surprisingly, most people pay attention to nonverbal cues as what they perceive as your intent. So you stand there with your arms crossed and somebody looks at you and right away they think that you're unapproachable or you're not going to listen to what they have to say. Remember, it's what they perceive. It's not what you're actually saying or what you're doing. It's how they perceive it. Communication is a complex process. We'll talk about Berlo. He has this communication tool. It has 5 parts: the stimulus, the sender, the message, the medium, and the receiver. All right, and each is a vital component. So the stimulus is what prompts someone to send you a message. And then we have the sender. That's the person that's sending that message. Then we have the actual message that's being sent. The medium, like the form that it's being sent, is it being sent auditory, visual, tactile, smell, or any combination of those things. And then we have the receiver. That receiver is the person who interprets the message and then responds by providing some sort of feedback. Feedback is a vital component of the communication process because it validates the accuracy of that person's message. So, one of the things I'll often ask nurses is, what is a tool that you use every day when you give someone a message to ensure that they understood that message and what you said to them? Also, if you could rate your communication skills on a scale of 1 to 10, what would you give it as far as a number? And why would you give it that number? What about your communication skills rated at that level? So in order for you to communicate with another, all right, you have a need. And this need is the stimulus. So for example, the communication could be a need for information, comfort, or advice. You walked into the room, your patient's in pain, and they grimace, right? That's the stimulus. Or they grimace because of the pain, right? The pain is actually the stimulus. Or they ask you, right out, I have pain for pain medication. Okay, so that would be the stimulus. The person sending the message would be that client, right? Sending you the message that they need this pain medication. Now, the message is the need for that pain medication itself. So if the person told you that they were in pain, all right, that would be auditory. If you looked at the person and they were verbal or even nonverbal, then you could have either a combination of auditory and visual. So they told you they were in pain. You looked at them, they grimaced. You saw that they were in pain. All right. And so now that is your media. Okay. And then we've now expressed to you, you've received the message, you've interpreted that we're in pain, and you responded by saying, oh, I see you're in pain, or oh, thank you for telling me you're in pain. I'm sorry you're in pain. I'll go get you something for your pain. All right, so you're responding in a manner that the patient understands that you heard the message, you've interpreted it. Or you could validate the accuracy by saying, are you in pain? Can you tell me your pain level? You see, and then at that point, you'll make a conscious decision as to what you're going to do. All right, so the person receiving the message would interpret that message and respond by providing that sort of feedback. In this figure, we see from the textbook the operational definition of communication. Communication itself is complex and it involves a variety of personal and environmental factors that can distort both the sending and receiving of the message. So just take a look at this and we'll probably talk through some of these things in the next several slides. So what kind of factors, environmental factors, can impede accurate communication? All right. Personal factors that can impede accurate transmission or interpretation of the message includes emotional factors like someone's mood, their response to stress, their personal biases, misunderstandings about the relationship, social factors such as previous experiences, cultural differences or language differences, lifestyle differences, cognitive factors such as problem-solving abilities, their level of knowledge, or language use. Environmental factors that affect communication include physical factors such as background noise, lack of privacy, uncomfortable conditions, social determinants such as some social-political history or economic factor, sometimes the presence or expectations of others. So, like, when mom's talking to a kid, and mom asks the kid a question, sometimes the kid will answer that question, or even with our significant others, sometimes those people will tell us what we want to hear because if they give us the other story, it's going to cause some sort of confrontation or some sort of argument. Other factors that can affect communication are the relationship. All right, how is our relationship with that person? Is it considered equal or unequal? So if we're considered equal, like friends, colleagues, then that relationship would be considered symmetrical. However, if there's a difference in status or power, like between us and our boss, or between the nurse and the client, or the teacher and the student, then it's characterized by inequality. So, meaning one participant is superior to the other. This is called a complementary relationship. Social status, age, gender differences, financial status, educational differences can also be influential in the communication process. We all have prejudices. Our duty to our patient is to guard against those negative feelings towards others who seem different from us. Those with different color of skin, those with different sexual orientation, those with different beliefs, those that were born in other countries, etc. So, from leading to demeaning or devaluing behavior towards another. We don't want to give that impression, but we all have that built in somewhere. And sometimes it might be in your conscious that's underwater. When Freud talks about our conscious, some is above water, some is underwater, our unconscious is more underwater. So sometimes this can be laying back there. In the United States, capitalism ties the systems of privilege. So we have these higher power groups and we have these low power groups that continue to be oppressed through economic control. So the higher status groups hold more power, they have more control over these lower status groups. And one way that power groups retain control is through stereotypes, prejudice, and biases. So they use these stigmas to keep the relationship out of balance, to keep themselves on top and everybody else on the bottom. Communication has two levels, the content level, which is verbal, and the process level, which is nonverbal. When the content is congruent with the process, the communication is said to be healthy. So congruent means it matches. In other words, you're telling me you're sad, you're crying, you have a depressed looking face. Or you're telling me that you don't feel well, you're short of breath, and your respirations are increased, I could see that your breathing is not as deep as it normally is and that it's faster. Incongruent would be like one time I was in the hospital in the emergency room and I had this lady next to me and she's on the phone for like 2 hours talking. And in the process of talking, she's saying, "Oh, I'm so short of breath." Really? You're that short of breath, but you're talking on the phone for 2 hours? I don't think so. So that would be incongruency. Like the symptoms don't match what they're saying. What they're saying, they're sometimes this can be affect. All right. The face, we talked about this a little bit ago. The face doesn't match what's going on. So, like I say to you, "Hey, my mom passed away and I'm laughing." All right. When I should be crying or sad. Right. So, that would be congruent, would be if I said my mom passed away and I was crying, that would be congruent. But if I said my mom passed away and I wasn't crying, it could be considered incongruent if I was laughing or doing something else. That also is affect. Also, remember we talked about affect. You should have an appropriate affect for the emotion or for the situation that's occurring. So I just don't want you to get confused on those two. All right. So when the content is congruent with the process, when whatever the person's saying matches what's going on with them, then that communication is said to be healthy. Verbal communication consists of all words that the person speaks. We live in a society of symbols, and our supreme social symbols are words. Talking is our most common activity, our public link with one another, the primary instrument of instruction. We need an art, and one of the most personal aspects of our private lives. When we talk or when we speak, we communicate our beliefs and values. We communicate perceptions and meanings. We convey interest and understanding or insult and judgment. We convey messages clearly, or sometimes we convey conflicting or implied messages. We may convey clear, honest feelings, or the feelings may be disguised or distorted. So we use clarification. And clarify means that we're clarifying certain words, and this is important. When the nurse and the patient have the same cultural background, the mental image they have of a given word may not be the same. Even though they're the same culturally, what they're talking about may not be the same. When we're talking to people from other cultures, the words that we say may not be the same. Although we may think we're talking about the same thing, the nurse and the patient may be talking about two totally different things. Right? Words are symbols for emotions as well as mental images. Nonverbal behaviors and cues can drastically influence communication. Effective communicators pay attention to both verbal and nonverbal cues. Nonverbal communication refers to any body gesture, such as a facial expression, body posture, hand movement, and so forth. The tone and pitch of a person's voice and the way a person paces speech are also examples of nonverbal communication. It's important to keep in mind, however, that the culture influences the pitch and the tone a person uses. For example, the tone and pitch of a voice used to express anger can vary widely within the culture or families. Other common examples of nonverbal communication, often called cues, are physical appearance, facial expressions, body posture, amount of eye contact, eye cast, where emotion is expressed in the eyes, size, fidgeting, and yawning. Look at Table 8.1 in your book. It identifies key components of nonverbal behavior. Nonverbal behaviors need to be observed and interpreted when you're considering a person's culture, class, gender, age, sexual orientation, and spiritual norms. A double bind is a dilemma in which communication in an individual or group receives two or more conflicting messages, with one message negating the other. A situation in which successfully responding to one message means failing with the other and vice versa, so the person will automatically be put in the wrong. A double bind is a no situation in which you are darned if you do and darned if you don't. So let's look at the examples for the double bind. So one example is a mom and a child, right? The mom offers words of love, telling the child how much she loves the child and everything, and at the same time, she nods in disgust at the child. So the child's confused and can't respond because her words say one thing, but her body language is saying something else. In example two, mom buys the son two shirts, one red and one blue. The first day, the child wears the blue shirt, and mom says to him, "Oh, you don't like the red shirt I bought you?" The second day, the child wears the red shirt, and mom says, "Oh, you don't like the blue shirt I bought you?" So the third day, the son doesn't know what to do, and he wears both shirts. Mom says, "Hey, son, you're driving me crazy." So here the child tries to find a compromise in order to satisfy the mom, but no matter what he does, the decision will be wrong because he's received conflicting information. So that's how a double bind works. Silence can be an effective tool when used properly. It helps individuals open up. However, it's often uncomfortable for both the nurse and the patient. In communication, we expect a high level of verbal activity. So, a lot of nurses find it uncomfortable when the words stop or when there's no talking. Silence is not the absence of communication, it's a specific channel to help transmit and receive messages. So nurses need to understand that silence is an important means of influencing and being influenced by others if used judiciously. It could be a powerful listening response. In the initial interview, the patient may be reluctant to speak because the newness of the situation may be overwhelming. The nurse is a stranger, and this may be uncomfortable for the patient. The patient may also be self-conscious, embarrassed, or shy. Talking is highly individualized. For instance, some people can talk on the phone for hours, and others find it to be a nuisance. People who are quiet, those who have a language barrier or speech impediment, older adults who may have hearing difficulties, and those who lack confidence in their ability to express themselves may communicate a need for support and encouragement through silence. There's no universal rule about how much silence is too much. Silence has been said to be worthwhile only when it serves as a function and it's not frightening for that client. Knowing when to speak during the interview largely depends on your perception about what is being conveyed through that silence. Icy silence is often an expression of anger or hostility. Being ignored or being given the silent treatment is recognized as an insult and can be a harmful form of communication. Silent may be related to anger, insulted feelings, or a lack of trust. Therapeutic silence can provide meaningful moments of reflection for both the participant and the nurse. It gives the client an individual opportunity to contemplate thoughtfully what has been said and felt, weigh alternatives, formulate new ideas, and gain new perspective on the matter under discussion. It gives the nurse the same advantage. If the nurse waits to speak and allows the client to break the silence, the client may share thoughts and feelings that otherwise would have been withheld. Nurses that feel compelled to fill every void with words often do so because of their own anxiety, self-consciousness, or embarrassment. When this occurs, the nurse's need for comfort tends to take priority over the need of the client. Prolonged, frequent silence by the nurse can hinder the interview that requires verbal articulation. Although untalkative, the nurse may be comfortable with silence. This mode of communication can make the client feel uncomfortable and cause the client to withhold information. The nurse needs to check with the client from time to time because without feedback, the client has no way of knowing if they're being understood. People want more than just a physical presence in human communication. They want the other person to be there for them, psychologically, socially, and emotionally. Active listening skills include the following: watching the patient's nonverbal behavior, listening to and understanding the patient's verbal message, listening to and understanding the person in the context of the social and cultural setting of their life, listening for false notes, like inconsistency or things that the patient says that need more clarification. Provide the patient with feedback about themselves of which the patient might be unaware. Effective interviewers must be accustomed to silence. It is just as important for effective interviewers to learn to become active listeners when the patient is talking as well as when the patient is silent. During active listening, the nurse carefully notes what the patient is saying verbally and nonverbally, as well as monitoring their own nonverbal responses. Using silence effectively and learning to listen on a deeper, more significant level to the patient as well as your own thoughts and reaction are key components of effective communication. When we use active listening, it strengthens our ability. It also strengthens the ability of the patient to use critical thinking in order to solve problems. Understanding depends on clear communication, and that is more effective when we verify with the patient what our interpretation of their message is. So we use therapeutic techniques. We request feedback on the accuracy of the message that we received from the verbal as well as the nonverbal cues. For example, you state to the patient, "I'm not quite sure what you were saying. Did you say you're not going to the group tonight?" By using these clarifying techniques, it helps both the client and us identify major differences in the frame of reference. It gives them an opportunity to correct any misperceptions on our part before they cause any serious misunderstanding. The client is asked to elaborate on or clarify any vague or ambiguous messages, and they need to know that the purpose of this is to promote mutual understanding. For clarity, the nurse might use paraphrasing, which means that the nurse restates in different but fewer words the basic content of the patient's message. Using simple, precise, culturally relevant terms, the nurse can readily confirm his or her interpretation of the patient's previous message before the interview continues. By prefacing statements with a phrase such as, "I'm not sure I understand," or "in other words, you seem to be saying," so this way the patient will restate. All right. In restating, the nurse mirrors the patient's overt and covert message. This technique can be used to echo feelings as well as content. Restating is different from paraphrasing in that it involves repeating the same key words the patient has just spoken. If your patient remarks, "My life is empty, it has no meaning," additional information may be gained by restating, "Your life has no meaning." The purpose of this technique is to explore subjects that may be significant. Reflection is a means of assisting people to better understanding their own thoughts and feelings. Reflection may take the form of a question or a statement that conveys the nurse's observation of the patient when sensitive issues are being talked about. The nurse might then describe briefly to the patient the apparent meaning of the emotional tone of the patient's verbal and nonverbal behavior. For example, to reflect the patient's feelings about his or her life, a good beginning might be, "You sound as if you've had many disappointments." Sharing observations with the patient shows acceptance. The nurse helps the patient become aware of feelings and encourages the patient to own those feelings. For example, the nurse may tell a patient, "You look sad." Perceiving the nurse's concern can allow the patient spontaneously to share feelings. The use of the question in response to the patient's question is also another reflective technique. A technique that enables the nurse to examine important ideas, experiences, or relationships more fully is exploring. For example, a client tells the nurse that he does not get along well with his wife. The nurse would want to further explore this area. Possible openers would include the following: Tell me more about your relationship with your wife. Projective questions can help people imagine the conflicts, thoughts, values, feelings, and behaviors they might have in certain situations. Projective questions usually start with a what if to help people articulate, explore, and identify thoughts and feelings. For example, if you had 3 wishes, what would you wish for? What if you could go back and change how you acted in a certain situation or a significant life event? What would you do differently now? What would you do if you were given $1 million, no strings attached? And then presupposition questions, or the miracle questions. Suppose you woke up in the middle of the morning and a miracle happened and this problem went away. What would be different? How would it change your life? These 2 questions can reveal a lot about a person and can be used to identify goals that the client may be motivated to pursue. They often get to the crux of what might be the most important issues in a person's thinking life. During active listening, nurses carefully note what the patient is saying verbally and nonverbally. They also monitor their own nonverbal responses. We use silence effectively, and we learn to listen on a deeper, more significant level to the patient as well as to our own thoughts and reactions. These are key ingredients to effective communication. These skills take time to develop but can be learned. You will become more proficient with guidance and practice. Listen to yourself. There are some principles that are important to active listening. These are always relevant. Everything you hear is modified by the patient's filters. Everything you hear is modified by your own filters. Every piece of communication must pass through 2 filters. It's okay if you feel confused or uncertain. Active listening will help strengthen the patient's ability to use critical thinking and help them problem solve. Give the patient undivided attention. This communicates to the patient that they are not alone. This kind of intervention will enhance the patient's self-esteem and encourage them to direct their energy towards finding ways to deal with their problems. When you serve as a sounding board, you listen to the patient. You test their thoughts by voicing them aloud. This form of interpersonal interaction enables the patient to clarify their thinking, to link ideas, and tentatively decide what should be done and how they should best do it. A husband is attending family therapy and tells his wife, "I'm listening. I want to support you in this." But he glares out the window and taps his foot when she starts to cry and explain her feelings. Which is the best description of his response? All right, so that was our double bind message, D. The husband is sending a mixed message, and this creates confusion. What is said and what is transmitted non-verbally, using a hurtful or negative message. A double bind message is when we mix content, what we say versus what we transmit non-verbally. It has a neutral and nurturing aspect, as in what is said, and a hurtful negative aspect, which is often implied. Cultural competence means being respectful and responsive to the beliefs and practices and the cultural and linguistic needs of our clients and of the diverse population groups that we'll be dealing with. Developing cultural competence is also an evolving, dynamic process that takes time, and it occurs along a continuum. There are 4 areas that may prove problematic for you as the nurse when you interpret specific verbal and nonverbal messages that the patient conveys: communication styles, use of eye contact, perception of touch, and cultural filters. Communicating across culture poses many challenges for all healthcare workers. We need a frame of reference to help us function. The trick is understanding that other people use many frames of reference to help them function in their world. Acknowledging that others view the world quite differently and trying to understand those views and the way people experience life and living in the world goes a long way towards minimizing our own personal distortions in listening and miscommunication. Building acceptance and understanding of those that are different from ourselves is a skill too. As the nurse, you have to have a strong understanding and awareness of your own cultural identity and biases. Your beliefs, your attitudes that you carry with you from your own cultural background are important. What's really even more important is your view of those that are from other diverse populations or subcultures, those that are ethnically different, those with alternate lifestyles, those that come from different socioeconomic classes, those with disabilities, those with lifestyle differences and elderlies. You have to be aware of your opinions about those people. Not having an awareness of those opinions or those biases can untowardly affect your communication or your relationship with other people. So be aware of your own attitudes. Communicating across the different cultures poses a challenge for all healthcare workers. We really need a frame of reference to help us function. The trick is understanding that other people may use many different frames of reference to help them function. Acknowledging how they view the world differently and trying to understand those ways of how they experience and live can go a long way towards minimizing our own personal distortions when we listen, and it can help us avoid miscommunication. Building acceptance and understanding of those culturally different from us is an art and a skill. Being aware of cultural meanings of certain verbal and nonverbal communications in our initial face-to-face encounters with those from different cultures can lead to formation of a positive therapeutic alliance, or it can cause us to become frustrated, angry, and develop misunderstandings. Stigmas, religious beliefs, and distrust of the medical profession are all communication barriers to forming alliances between African Americans and healthcare workers from the dominant American culture. So look at this chart and compare and contrast the range of verbal and nonverbal communication of your cultural group with two other groups in the area of communication styles. So think about eye contact and touch and give some examples. Some ethnic backgrounds may communicate in an intense and highly emotional manner. For example, the perspective of a non-Hispanic person, many Hispanic Americans may appear to use dramatic body language when describing their emotional problems. Such behavior may be perceived as out of control and therefore viewed as having a degree of pathology not actually present. In other cultures, a calm facade may be masking severe distress. For example, in Asian cultures, expression of either positive or negative emotions is a private affair. So open expression of emotions is considered to be in bad taste and possibly a weakness. A quiet smile by an Asian American is a signal of a variety of emotions. A smile might be an expression of joy, an apology, stoicism in the face of difficulty, or even in anger. In general, Asian individuals exercise emotional restraint when they communicate, and interpersonal conflicts are not directly addressed or even allowed. The presence or absence of eye contact should not be used to assess for attentiveness, to judge truthfulness, or make assumptions on the degree of engagement one has with the patient. Culture dictates a person's comfort or lack of comfort with direct eye contact. Some cultures consider direct eye contact disrespectful and improper. In some Hispanic cultures, or subcultures, individuals have traditionally been taught to avoid eye contact with authority figures such as nurses, physicians, and other healthcare professionals. Avoidance of direct eye contact is seen as a sign. So sometimes when we're communicating with clients, we'll do things that either obstruct the communication or interfere with it. And we're going to talk about some of those things. So one thing is giving premature advice, such as you need to get out of this situation immediately. This assumes that you as the nurse know better than the client and that the client is incapable of thinking for themselves. It inhibits problem-solving abilities for the client, and it fosters dependency. Advice. So we give advice a lot in daily life, and people ask us for advice all the time. But when we talk about giving advice to a client, it's not generally helpful. Often when we ask for advice, our motive is to discover if we're thinking along the same patterns or lines as someone else, and we're trying to determine if they would agree with us. When the nurse gives advice to a client that's having trouble assessing and finding solutions to certain conflicts in their life, the nurse interferes with that client's ability to make their own personal decision. When we give a person a solution, it robs them of the ability to think for themselves and to take on self-responsibility. The nurse offers patient or client solutions. The client eventually begins to think that the nurse does not view the client as capable as making effective decisions. Minimizing feelings. The patient states, "I wish I were dead," and the nurse responds, "Everybody gets down in the dumps." This is indicating that as the nurse, you're unable to understand or empathize with the client. The client's feelings or experiences are being belittled with this statement, and that can cause the client to feel small or insignificant. When we empathize or explore, we make statements like, "You must be feeling very upset. Are you thinking of hurting yourself?" False reassurance. Clients make a statement to us and then we respond by saying, "I wouldn't worry about that." This underrates the patient's feelings and belittles the client's concerns. It can cause the client to stop sharing feelings with us, and if the patient thinks he or she will be ridiculed or not taken seriously, they may not communicate. Clarifying the client's message, "What specifically are you worried about?" is a better way to approach a situation like this. Making valued judgments. Asking the client questions such as, "How come you still smoke when your wife has lung cancer?" This interferes with the client's ability to problem solve. You can make the client feel guilty, angry, or misunderstood and not supported or anxious to leave. When you make observations, it's better. "I noticed that you are still smoking even though your wife has lung cancer. Is this a problem?" Asking why questions. When we ask why questions, it puts the patient on defense and it implies criticism. "Why did you stop taking your medication?" And then asking excessive questions. Excessive or multiple questions at the same time, especially close-ended questions, cast the nurse in the role of an interrogator, raising a demand for information without respect for the client's willingness or readiness to respond. This approach conveys a lack of respect for sensitivity to the patient's needs. Giving approval or disapproval. "Hey, you look great in that dress. I'm proud of the way you controlled your temper at lunch. That's a great quilt you made." What could be bad about giving someone a pat on the back once in a while? Nothing if it's done without carrying either a positive or a negative judgment by the nurse. The client may be feeling overwhelmed, experiencing low self-esteem, or feeling unsure of where he is in where they are in their life or where they're going. and consequently they may feel needy for recognition, approval, or attention. When people feel vulnerable, a value comment can be misinterpreted. For example, giving approval. You did a great job in the group telling John what you thought about how rudely he treated you. This message implies that the nurse was pleased in the way that the client talked to John. The client then sees a response as a way to please the nurse by doing the right thing. So John continues to try to please the nurse and get approval and continues the behavior. The behavior might be useful for the client, but when a behavior is being done to please another person, it's not coming from that client's own volition or conviction to do so. Disapproving or disagreeing. You really should have shown up for the medication group. I disagree with that. Can make a person defensive. Changing the subject. The patient states, I'd like to die, and the nurse states, did you go to Alcoholics Anonymous like we discussed? This can invalidate the client's feelings and needs and leave the client feeling alienated, isolated, and increase their feelings of hopelessness. Validating and exploring is a better choice. The client states, I'd like to die, and the nurse states, this sounds serious. Have you thought of harming yourself? Paplow emphasized the art of communication in order to highlight the importance of nursing interventions in facilitating the achievement of quality patient care and quality of life. The goal of the nurse in the mental health setting is to provide a place of safety and hope where the client can feel comfortable and understood. Long-term goals are created to help the client identify and explore problems related to others, discover healthy ways of meeting emotional needs, and experience satisfying interpersonal relationships. Once the client's specific needs and problems are identified, the nurse can work with the client to help increase critical thinking skills, teach them new coping behaviors, and help them experience more appropriate and satisfying ways of how they relate to others. To do this, the nurse must have a sound knowledge of communication skills. The nurse can best serve their clients when they become more aware of their own interpersonal methods and work on eliminating obstructive, non-therapeutic techniques while developing helpful therapeutic techniques. This can maximize the nurse-client interaction. As the nurse, you must develop good therapeutic communication techniques to interact with your client. We're going to talk about some of these techniques. The first one we're going to talk about is using silence. When we use silence, this gives a person time to collect their thoughts or think through a point. It encourages the person to talk by waiting for the answer. When we use silence properly, it's an effective tool in encouraging our clients to open up. However, silence is sometimes uncomfortable for both the client and the nurse. In nursing, there's an emphasis on action. In communication, we expect a high level of verbal activity. Sometimes students or practicing nurses find that when the flow words stop, they suddenly become uncomfortable. Silence is not the absence of communication, but a specific channel that allows us to transmit and receive messages. The clinician must understand that silence is a significant means of influencing and being influenced by others, and if we use it correctly, it's a powerful listening response. In the initial interview, the client is often reluctant to speak because of the newness of the situation, and they may feel overwhelmed. The nurse is not someone they know, and that may cause uneasiness. The client may feel self-conscious, embarrassed, or shy. Talking is a highly individualized thing. Some people find the telephone to be annoying, while others talk and text on it constantly. The nurse has to recognize and respect individual differences in styles, tempos of responding. People that are quiet often have a language barrier or speech impediment. Older adults are often hard of hearing And sometimes people lack confidence in their ability to express themselves and may communicate a need for support or encouragement through their silence. There is no universal rule for how much silence should be used. Silence has been said to be worthwhile only when it serves a function and it's not frightening for the client. Knowing when to speak largely depends on your perception and what is being conveyed through the silence. Icy silence sometimes conveys anger or hostility. Being ignored or being given the silent treatment is frequently seen as an insult and can be a harmful form of communication. Silence may relate to anger, insulted feelings, or a lack of trust. Therapeutic silence can provide a meaningful moment of reflection for both the client and the nurse. It gives each party an opportunity to contemplate thoughtfully what has been said and felt and weigh alternatives or formulate new ideas to gain new perspective on the matter. If the nurse waits to speak and allows the client to break the silence, the patient may share thoughts and feelings that they otherwise would have withheld. Nurses that feel compelled to fill every void with words often do so because of their own anxiety, self-consciousness, and embarrassment. When the nurse does this, her need or his need for comfort takes over the priority needs of the patient. Prolonged and frequent silence by the nurse can hinder an interview and make the patient feel uncomfortable and withhold information. The nurse must check with the client from time to time because without feedback, clients have no way of knowing whether they are being understood. Accepting. Be accepting. This indicates that the person has been understood, and it doesn't necessarily indicate agreement, but it's non-judgmental. Nurses should not indicate that they understand something or imply that they indicate that they understand something when they don't. Offering of self. Giving recognition. Giving recognition indicates awareness of change and personal efforts. It does not imply good, bad, or wrong. Good morning, Mr. James. You've combed your hair today. Offering of self. When you offer of yourself, you offer your presence, you offer a desire to understand what the patient is saying or how they're feeling, and it shows that you're interested in the client. So ways that you can verbalize that to the client is by stating things like, I'll sit here or I'll stay here with you for a while. Offer general leads. This allows the other person to take direction in the conversation. It tells the client that the nurse is interested in what's coming next. So say things like, go on, tell me about it. How do you feel? Giving broad openings. This clarifies that the lead is being taken by the client. However, the nurse discourages pleasantries and small talk. What are you thinking about? Or what would you like to discuss? Placing the events in time or sequence. This puts the events and actions in better perspective. It notes cause and effect relationships and helps us identify patterns of interpersonal difficulty, like what happened before, when did this happen? Offer or make observations. This brings attention to the person's behavior. So if they're doing things like trembling or nail biting, or if they're restless, it encourages the person to notice that behavior and describe their thoughts and feelings. So for mutual understanding, it's helpful with people that are mute or withdrawn. You could say something like, you appear tense, or I noticed that you're biting your lips. Encourage description of perception. This increases your understanding of the patient's perception. Get the patient to talk about their feelings and their difficulties can lessen the need for them to act out inappropriately. So ask the client, what do these voices seem to be saying? Or tell me when you feel anxious. Encourage the client to compare. This allows recurring themes in experiences or interpersonal relationships. It helps the client clarify similarities and differences. So ask the client, has this ever happened before? Or is this how you felt when, some other situation similar to this occurred? Restate. This repeats the main idea that was expressed, and it gives the client an idea of what has been communicated. If the message has been understood, the client can clarify it. So the client states, I can't sleep, I stay awake all night, and the nurse repeats back, you have difficulty sleeping. Reflecting. This directs questions, feelings, and ideas back to the patient. It encourages the client to accept their own feelings and ideas. It helps us acknowledge the client's right to have an opinion and to make their own decisions. And it encourages the client to think about themselves as a capable person. So the client states, what should I do about my husband's affair? And the nurse responds, what do you think you should do? Another technique is exploring. When we use exploring, we look at the ideas, the experiences, or the relationships more in depth, and we thoroughly examine it. If the client chooses not to elaborate by answering no, then we have to respect the client's wishes. So we state to the client, tell me more about that. Would you describe it more fully? And of course, if they decline, then you'll respect that wish. Giving information. This makes available facts that the client needs. So we supply knowledge from decisions that can be made or conclusions drawn. For example, the client needs to know what the role of the nurse is, the purpose of the nurse-client relationship, the time, the place, and the duration of meetings. My purpose for being here is, I'm here to draw blood today. I'm here to do a head to toe physical on you today. I'm here to take you to group therapy today. I'm here to give you your medication today. This medication is for your schizophrenia. This medication is for your bipolar disorder. This medication is for your extrapyramidal symptoms. Seeking clarification. Clarification helps the client clarify their own thoughts and maximize mutual understanding between the nurse and the client. Stating things like, I'm not sure I follow you, or what would you say is the main point of what you just said. Presenting reality. This indicates what's real. You don't try to argue or try to convince the patient, you just describe personal perceptions or facts in the situation. That was Dr. Todd, not a terrorist stalking and trying to harm you. Voicing doubt. Voicing doubt undermines the patient's beliefs by not reinforcing the exaggerated or false perceptions. Isn't that unusual, or that's hard to believe? Seeking consensual validation clarifies that both the nurse and the client share a mutual understanding of the communication. This helps the client become clearer about what he or she is thinking. Tell me whether my understanding agrees with yours. And then verbalizing the implied. This puts in concrete terms what the client implies, making the client's communication more explicit. So the client says, I can't talk to you or anyone else. It's a waste of time. And the nurse responds, do you feel that no one understands? Encouraging. When we encouraging evaluates and helps the patient consider people and events from the perspective of their own set of values. So we ask them directly, how do you feel about and then, subject would go in there. What did it mean to you when he said he couldn't stay? So we're asking, the client's perception or perspective of how they feel. Attempting to translate into feelings. This responds to the feelings that were expressed, not just to the content, often termed decoding. So the client states, "I am dead inside," and the nurse responds, are you stating that you feel lifeless?" Suggesting collaboration. This emphasizes working with the client, not doing things for the client. It encourages the view that change is possible if we work together or collaborate. So we state to the client, perhaps you and I together can discover what is producing your anxiety. We can sometimes summarize. This combines the important points of the discussion to enhance our understanding. It also allows an opportunity to clarify communication so that both the nurse and the client leave the interview with the same idea in mind. During the past hour, you and I have discussed the following. That would be an example. Encouraging formulation of a plan of action. This allows the client to identify alternative actions for interpersonal situations that they find disturbing. So situations that make them angry or that produce anxiety in them. For example, the next time this comes up, what might you do to handle it? What are some other ways that you could approach your boss, or what are some other ways that you could handle this situation? So we're teaching the client how to respond differently. Focusing concentrates attention on a single point. It's particularly useful when the client jumps from topic to topic. So if the client is experiencing a severe or panic level of anxiety, the nurse should not persist until that anxiety lessens. And then we might make a statement such as, the point you are making about leaving school seems worth looking at more closely. So that would be an example of focusing. Try to role play with a classmate, and we're going to use the techniques of what if and the miracle question, and then switch roles. And then discover what new information you've learned about your classmate, what new insights you may have learned about yourself. So the next two slides will explain the what if and the miracle question. If you're at home and you're watching this video, you could actually do this with your partner and maybe even one of your kids, like one of your older children. Suppose you woke up in the morning and a miracle happened and this problem you had gone away. What would be different? How would it change your life? These two questions can reveal a lot about a person and can be used to identify goals that the client may be motivated to pursue. And they often get to the crux or, to the problem of what might be the most important issue in a person's thinking or life. So we start with a what if question to help people articulate, explore, and identify their thoughts and feelings. If you had 3 wishes, what would you wish for? What if you could go back and change how you acted in a particular situation or in a significant life event? What would you do differently now? What would you do if you were given $1 million, no strings attached? Projective questions often help people imagine thoughts, feelings, and behaviors they might have in certain situations. So this is the presupposition question, and it's called the miracle question. Again, suppose you woke up in the morning and a miracle happened and this problem had gone away. What would be different? How would it change your life? These two questions can reveal a lot about a person which can be used to identify goals that the client might be motivated to work on. These questions often get to the crux of what might be among the most important issues in a person's thinking and life. Telehealth is becoming extremely popular now, especially with the nursing shortage and trying to get healthcare out to some communities where they're rural or they don't have certain things available to them. Mental health being one of those, because there is a shortage right now in mental health nurses, doctors, just treatment in general. So when we use telehealth, we use electronic information and telecommunication technology to support the long-distance clinical health and help eliminate barriers from the delivery of healthcare services. So we're trying to get rid of some of those disparities in healthcare. Telehealth technologies like electronic means of communication, such as video conferencing, the internet, telephones, consultations and counseling, image transmission, and interactive video sessions help us establish and maintain therapeutic communications to some of these people that are living in these more rural areas or might not have the capability to get out of the house because of some sort of disability. Particular attention must be paid and directed to confidentiality, informed consent, documentation, maintenance of records, and integrity to information that is being transmitted, especially across any sort of fax, internet, anything like that. We have to be extremely careful. Now, informatics and information technology are being adopted in medical and mental health care in the United States. These sophisticated technologies really started with the military when they would bring their soldiers to places like Iraq or in these countries where they didn't have access to their routine doctors. They were able to bring all their healthcare records there and make sure that they were providing the best care for these soldiers by not giving them treatment without having full access to their medical records and knowing what all their problems were. So now hospitals have incorporated computerized systems that talk to each other. Very expensive computerized systems. Most of the hospitals have incorporated them now. So they have these computers on the floor that talk to the ones on the pharmacy, that talk to the ones over here and over there. So that's really what informatics is about, is how these different computers communicate to each other so that we're not jeopardizing our patient's safety, we're not engaging in things like polypharmacy, and we're not treating patients without having full access to all their medical history and issues. All right, so informatics and information technology continue to be adopted in the United States, and the adoption of this sophisticated information communication technologies is associated with greater use of pre-established medical protocols, higher patient satisfaction. Some of this also came from Medicare and Medicaid. They wanted to use these electronic health records, and so they offered incentives to different doctors, or they would actually penalize different companies if they didn't put these electronic health records in place. So that also prompted a lot of this informatics, because prior to all that, these technologies weren't always in place. So Medicare put it in place for one reason, to stop them from getting overbilled by different doctors, because one doctor was billing them for the same thing that another doctor might be billing them for. So they wanted to put a stop to that as well. So by incorporating these informatics and incorporating electronic health records, they can make the information more accessible to the patient. They can provide more transparency for the consumer. So if a patient wants to go into a hospital and have a procedure done, they can go in there and look at the hospital and see what their outcomes are. Like, I want to have knee surgery. What are their outcomes? Do they meet certain quality indicators? And so it's all about patient safety, tracking clinical progress, making sure people have access to good medical help, and things like that as far as the informatics. All right, so when we can provide telehealth to people, then we can also provide healthcare to them who might not always have, accessibility to that healthcare, and whether it be medical or psychological help. This telehealth can help us relieve the nursing shortage. All right, so besides providing that better health care for those in the rural areas and those that can't travel, telehealth is a way to relieve that impending nursing shortage. Nursing schools right now are having difficult times meeting the shortage because of a decrease in financial resources and retiring faculty. So, use of telehealth home care technology allows a nurse to monitor the patients, the vital signs, the lung sounds, and identify changes in different physiological states. It allows clinicians to conduct physical assessment and consults. That's helpful for facilities that have those limited nursing resources, especially like schools, prisons, certain clinics, or rural hospitals. So it's currently estimated that about 1 in 4 adults are diagnosed with mental health problems. Mental health problems range from things like anxiety, stress, marital issues, depression, to substance abuse. Most mental health issues are not addressed because of the fear of stigma, the scarcity of the healthcare providers, especially in those remote areas, or problems with transportation because of anxiety, physical limitations, or lack of transportation in of itself. The consequences of not seeking help can be important and can range from problems at work to domestic violence, increased depression, and suicide. So, telehealth will help us provide services to people to prevent some of these issues. Otherwise, these consequences will result in a host of other ramifications. The U.S. Department of Defense is currently expanding its ability to deliver telehealth services to active duty military personnel in its international setting, and to veterans and their families by designating a provider of telemedicine services to operate on its networks using a service called Global Med. This is an international provider of telehealth services. These technologies are used for telepsychiatry appointments ranging from treating PTSD, post-traumatic stress disorder, and depression to providing wellness and resiliency interventions, especially in rural areas. These technologies also help facilitate health assessments, diagnoses, treatments, and interventions, as well as clinical consultations to all Department of Defense members. According to Peak, mobile phones are the most quickly adopted consumer technology in human history. Beginning in approximately 2013 to 2016, the number of adults 65 and older who reported owning a smartphone rose from 18 to 42% in the United States. Psychiatric patients own smartphones at high rates and are interested in using them to monitor their mental health based on published surveys. There are thousands of applications that support and target psychiatric conditions. However, there is less clinical research on these apps. For depression and bipolar disorder, one review found less than 15 published studies. There are also concerns for unintended adverse effects in app usage. There is growing interest in using passive data information. Which patient is the least likely candidate for telehealth therapy? A. A depressed mother in an underserved area. B. A soldier in Afghanistan. C. An adolescent in a rural family. Or D. A violent man threatening harm to his family. D. A violent man threatening harm to his family. Telehealth offers distinct advantages to isolated individuals and is making a difference in reaching untreated patients with mental health problems. However, a disadvantage for patients who need physical intervention is that, of course, long-distance care. Developing competent communication and interviewing techniques is the foundation for patient-centered partnerships. Goal-directed professional communication is referred to as therapeutic communication. Communication is a complex process. Berlow's communication model has 5 parts: the stimulus, the sender, the message, the medium, and the receiver. Feedback is a vital component of the communication process for validating the accuracy of the sender's message. A number of factors can minimize or enhance the communication process. For example, differences in culture, language, knowledge levels, noise, lack of privacy, the presence of others, and expectations can all influence communication. There are both verbal and nonverbal elements in communication. The nonverbal elements often play a larger role in conveying the person's message. Verbal communication consists of all words a person speaks. Nonverbal communication consists of the behaviors displayed by an individual in addition to the actual content of speech. Communication has 2 levels: the content level, verbal, and the process level, nonverbal behavior. When content is congruent with process, the communication is said to be healthy. When the verbal message is not reinforced by the communicator's action, the message is ambiguous. We call this a double or mixed message. Cultural background as well as individual differences has a great deal to do with what nonverbal behavior means to different individuals. The degree of eye contact and the use of touch are 2 nonverbal aspects that can be misunderstood by individuals of different cultures. There are a number of communication techniques that nurses can use to enhance their nursing practices. Many widely used communication enhancers are cited in your book in Table 8.2. There are a number of non-therapeutic techniques that nurses can learn to avoid in order to enhance effectiveness with people. Some are cited in Table 8.3 in your book, along with suggestions for more helpful responses. Nurses are more effective when they use non-threatening or open-ended communication techniques. Effective communication is a skill that develops over time and is integral to the establishment and maintenance of a therapeutic alliance. The application of information communication technologies is the psychosocial science and is relatively new, but is viewed as a tool for helping people with mental health needs. It's particularly well suited for individuals in rural areas and for those individuals for whom accessing healthcare mental health clinics is not possible either physically or financially. The use of apps or applications for those with anxiety, depression, and other mental health issues such as post-traumatic stress, bipolar disorder, etc. can provide greater accessibility to psychiatric care. The one caveat is that the app should be approved and well accepted within the mental health community.